Hi, y'all, and welcome to Professor Truelove's Concepts for Nurses series. I am Professor Terry Truelove, and in this episode, part of the cardiology series, we are going to be looking at specific EKG rhythms and dysrhythmias. In this episode, we'll cover sinus rhythms, part 1. Sources for this episode include Cohn's Flippin' C ECG, 4th edition. Research has revealed that the impulses that go through the heart go, for the most part, in a specific and recordable pattern. That pattern is known as normal sinus rhythm. And here you have an example of normal sinus rhythm. Notice that both the atrial and ventricular rhythms are essentially regular. There can be a slight variation in the rhythm, and that would be considered normal. In this example, the atrial and ventricular rates are both 83 beats per minute. There is one P wave before each QRS complex, and the P waves are of consistent morphology, or shape. The PR interval measures 0.18 seconds and is constant, and the QRS measures 0.06 seconds and is also constant. The timing, intervals, and shape are all characteristics of normal sinus rhythm, and using the algorithm introduced in another episode, we see that the rhythm is regular, that the rate is between 60 and 100 beats per minute, that there are P waves present with a consistent configuration, and that there is one P wave before each QRS complex. Further, that the PR interval is indeed between 0.12 and 0.20 of a second, and it's constant, and the QRS duration is between 0.04 and 0.10 or 12 of a second, and also constant. You know that some sources state that the normal QRS duration is 0.04 to 0.10 second, and others between 0.04 and 0.12. Both are essentially correct. In addition, the QT interval should be between 0.36 and 0.044 seconds, and that the T waves and the ST segments should look normal and upright. Normal sinus rhythm is the expected rhythm of a healthy adult. Remember, we usually identify it in a positive lead, and normal sinus rhythm is the basis to which we compare all other rhythms. By definition, all other rhythms are dysrhythmias or arrhythmias. In this image, we see normal sinus rhythm as viewed from a negative lead. So you will notice that the P wave deflects downward, as does the QRS and even the T wave. This confirms our suspicion that we are looking at normal sinus rhythm. But we should go through the algorithm, making sure that it is regular, that the rates between 60 and 100, that our intervals are of correct time as well. Once we do all of that, we know that this is indeed normal sinus rhythm, simply read from lead AVR, one of the negative leads. And if you're still not sure that you're looking at sinus rhythm, switch the lead. You may switch it to a positive lead to get it to look a little more like what you were expecting. Because what you're hoping doesn't happen is that you have a dysrhythmia. So let's look at some sinus dysrhythmias. Sinus dysrhythmias are variants of normal sinus rhythm, and the origin of the impulse is from the sinoatrial node. Let's look first at the dysrhythmia sinus bradycardia. Sinus bradycardia is nearly exactly the same as normal sinus rhythm, except for one important change, the rate. In this case, the rate will be less than 60 beats per minute. Otherwise, it is irregular. The rate, number 2, is below 60. That makes it a bradyarrhythmia. However, the P waves are uniform. They are regular, and there is one for every QRS. The PRI is 0.12 to 0.20 seconds, and the QRS interval is between 0.04 and 0.12 seconds, and the QT interval is going to be greater than 0.044 seconds because QT intervals tend to expand, that is, get longer, the slower the heart rate is. Sinus bradycardia is actually very normal and may be found during sleep, or if a person has a well-conditioned heart, An athlete, for example, they may have a sinus bradycardia, and this is because their cardiac output is okay. You should recall the formula stroke volume times heart rate equals cardiac output. If I am a healthy athlete, I have such a powerful stroke volume that during periods of rest or sleep, I may not need my heart to beat as frequently in order to maintain the same cardiac output. And this is because in an otherwise healthy cardiovascular system, sinus bradycardia occurs as the normal response to a reduced demand for blood flow. In some cases, vagal stimulation increases and sympathetic stimulation decreases, causing the sinus bradycardia. As a result, automaticity, that is, the tendency of the cells to initiate their own impulses in the SA node, diminishes. And although sinus bradycardia should be considered a normal condition under the right circumstances, it can occur because of pathologies. In fact, it commonly occurs after an inferior wall MI because this involves the right coronary artery, which supplies blood to the SA node. It can also result from numerous other conditions and the use of certain drugs known as negative chronotropes, that is, medications that decrease the heart rate. The clinical significance of sinus bradycardia depends on how low the rate is and whether the patient is symptomatic. For example, most athletes can tolerate a sinus bradycardia of 45 to 59 beats per minute, but they are less tolerant with heart rates of less than 45 beats per minute. So when do you know to worry? When do you act? Well, if there are no symptoms, there is no problem. Usually, sinus bradycardia produces no symptoms and is insignificant. Unless the patient shows symptoms of decreased cardiac output, no treatment is necessary. However, if there are symptoms, difficulty breathing, confusion, cool skin, etc., it's a problem and prompt attention is critical. That is because the heart of a patient with underlying cardiac disease may not be able to compensate for a drop in rate by increasing the stroke volume. The resulting drop in cardiac output produces signs and symptoms such as hypotension and dizziness. Also, bradycardia may predispose some patients to more serious arrhythmias, such as ventricular tachycardia and even ventricular fibrillation. So, as you're looking at this strip, what should you look for? Well, atrial and ventricular rhythms and rates are regular. The rates are less than 60 beats per minute, but all other characteristics appear normal. Each P wave precedes each QRS, and there is a normal PR interval, there's a normal QRS complex, there's a normal T wave, and a normal QT interval. Compensatory mechanisms mean it is likely the patient will remain asymptomatic. If, however, those compensatory mechanisms fail, the signs and symptoms of declining cardiac output, such as hypotension and dizziness, begin to appear. Palpations and pulse irregularities may occur if the patient experiences more ectopic beats on top of the sinus bradycardia, such as PACs, PJCs, and PVCs. As the blood flow to the brain decreases, this can lead to a decreased level of consciousness, and that can manifest itself into such symptoms as confusion. There's a name for this. It's called bradycardia-induced syncope, or a Stokes-Adams attack. Realize your patient has safety risks, such as risk for falls. A different type of sinus dysrhythmia is known as sinus tachycardia. In sinus tachycardia, the heart rate is greater than 100 beats per minute, but essentially the pattern is the same. The rate of sinus tachycardia very rarely exceeds 160 beats per minute, except maybe with very strenuous exercise. The maximum possible rate achievable with exercise continues to decrease with age. So the clinical significance of sinus tachycardia depends on the underlying cause. Because the arrhythmia may be the body's response to exercise or even a high emotional states, and is in these cases is probably of no clinical significance. Remember that it can also occur with hypovolemia, hemorrhage, or pain. When the stimulus for tachycardia is removed, the arrhythmia spontaneously resolves. Like sinus bradycardia, sinus tachycardia can have profound effects on the body. Because of the myocardial demands for oxygens are increased at these higher heart rates, tachycardia can bring on an episode of chest pain in patients with existing coronary artery disease. An increase in heart rate can also be detrimental for patients with obstructive types of heart conditions, such as those patients with aortic stenosis and hypertrophic cardiomyopathy. Sinus tachycardia occurs in about 30% of patients who have suffered an acute MI and is also considered a poor prognostic sign because it may be associated with massive heart damage. If the ventricles are damaged enough, they won't be able to have an adequate stroke volume. Your compensatory mechanisms are going to have the heart rate increase. If the patient's had a heart attack, that's a very bad sign. Because of this, persistent tachycardia may also signal impending heart failure or cardiogenic shock. The causes of sinus tachycardia may be a normal response to pain, exercise, stress, fever, or strong emotions, such as fear and anxiety. Certain cardiac conditions, such as heart failure, cardiogenic shock, and pericarditis, can also lead to sinus tachycardia. Sinus tachycardia may be a compensatory mechanism for shock, anemia, respiratory distress, pulmonary embolism, sepsis, and hyperthyroidism. Medications such as atropine, isoproterenol, aminophylline, dopamine, dobutamine, epinephrine, alcohol, caffeine, nicotine, and amphetamines are all known to have an adverse effect that causes sinus tachycardia. So, on the rhythm strip, you should look to see that the atrial and ventricular rhythms are regular, that both rates are equally and are usually between 100 to 160 beats per minute, that the P wave is of normal size and shape and precedes each QRS, but it may increase in amplitude. As the heart rate increases, the P wave may actually be superimposed on the preceding T wave, and that may start to make it difficult to identify. That's one of the other reasons that at about 160 beats per minute, it gets a little difficult to truly know if this impulse is coming from the sinus. It may be coming from the atria or somewhere else above the ventricles. This is when we start to call these rhythms supraventricular tachycardias. However, if the heart rate's between 100 and 160, continue to look to make sure that the PR intervals, the QRS complexes, and T waves are all normal, and the QT interval is normal, although remember, in faster rates, the QTI tends to get shorter. Tachycardia can lower cardiac output by reducing ventricular filling time and the amount of blood pumped by the ventricles during each contraction. Normally, ventricular volume reaches 120 to 130 milliliters during diastole. However, in tachycardia, there is decreased time to fill up the ventricles, and this can lead to hypotension and decreased peripheral perfusion. This is particularly alarming in conditions like myocardial infarction, because tachycardia worsens myocardial ischemia by increasing the heart's demand for oxygen and reducing the duration of diastole. During diastole, that is the period of greatest coronary artery flow. One of the main points of treatment for sinus tachycardia is to determine the cause of that tachycardia. Treatment for symptomatic patient involves maintaining adequate cardiac output and tissue perfusion, and again, identifying and correcting that underlying cause. For example, if the tachycardia is caused by hemorrhage, treatment includes stopping the bleeding and replacing blood and fluid. So, slow the heart rate down, particularly if the tachycardia is leading to cardiac ischemia. The treatment plan may include medications to slow down the heart rate. The most commonly used drugs to do so include beta-adrenergic blockers such as metoprolol and atenolol, and calcium channel blockers such as verapamil. The nurse should also check the medication history. This is because many of the over-the-counter medications purchased contain sympathomimetic agents. And remember, these imitate chemicals normally found when there is a stimulus to the sympathetic nervous system. and many of these agents are found commonly in nose drops and in cold formulas. You should also ask the patient about their use of caffeine, nicotine, alcohol, and recreational drugs such as cocaine and amphetamines, all of which can trigger tachycardia. Check for chest pain because sinus tachycardia can lead to further injury of the heart muscle. Assess for signs and symptoms of heart failure, including crackles, an S3 heart sound, and jugular vein distension. Monitor intake and output, as well as daily weight, and teaching should include not only avoiding those substances, but also relaxation techniques, stress reduction techniques, and healthy living. That does end this episode. However, there is still more adventures in diagnosing sinus rhythms. So I hope you learned a little bit today, and I hope you come back. And if you do, we'll see you then.